Hi, I'm Dr. Hall. Thank you so much for joining us this afternoon. One of the osteopathic medicine doctors, and I'm also certified in family medicine as well. And your new clinic is on 945 Main Street in Manchester. And this is my colleague, Dr. Dennis Burke. Who's just going to do a presentation on what is osteopathic medicine, although I know some of you already know what it is, but how it is a holistic approach to pain management. So what have you heard about osteopathic medicine? For some of you, what do you know about it so far? So what it is, we'll go over what that is, the definition of osteopathic medicine, and the history of how it came to be, review what makes up the osteopathic medicine, namely the principles and practice. Who practices this type of medicine? Basically, what is a DO? And then what's our educational background and how we different from chiropractors, who we can help. Let's do a little demonstration. And we'll also have some diagnostic and treatment tools. And we'll also go over a little bit of some of the stuff that we treat, which actually Dr. Burke will be taking over that part. So there's two types of medical schools in the United States. There's medical doctors, which are the MDs. This is also known as the allopathic medical school. They go to college. They have the standardized exams that they need to get in. Much like the DOs, same thing. And they have 12 to 24 months in the classroom. Beyond that, be clinical. After that, and then they go to a residency of their choice. It's for further training. And usually they focus on making a diagnosis and treating symptoms and illness. Versus the doctors of osteopathic medicine, our education is similar, but we have osteopathic medical schools, which same standardized tests and GPAs get in. And then the curriculum is 12 to 24 months, just like the medical doctor. But then we have an additional 200 plus extra hours training in musculoskeletal system in osteopathic manipulative medicine. That's also incorporated on top of that. So we have to learn what they learn and extra stuff. So we also focus the philosophies, which you'll see throughout the presentation, that we focus on the whole person and their lifestyle for treating a condition rather than just that condition, symptom, and illness. So osteopathic medicine is founded upon osteopathy, which is the science of medicine and healing and art and a philosophy. It's a distinctive system of medical diagnosis and treatment, and its principles are profound and inclusive. Being at the best of science and healing arts directed towards the whole body, and we're targeted at mind, body, and spirit. So is osteopathic medicine new? No, it's been around for at least 150 years or more. And it was founded by this doctor. His name is Dr. Andrew Still, also known as A.T. Still. And back in 1874, it created and gave he gave this world a new philosophy, the osteopathic world, a new philosophy, perspective and holistic medicine. So treating the mind, body, spirit, that's going to be a common motif for this presentation. So he founded this philosophy after the U.S. Civil War, in which he was an officer and a physician. He was a surgeon, American frontier doctor who was convinced that 19th century patient care was severely inadequate. So he coined the word osteopathy, word osteopathy from two Greek derivatives, osteon meaning bone and pathos meaning suffering, pathology. And it signifies a system of healing that recognized that you want to be treated first, or the deepest level of human suffering. So he founded the first osteopathic school in Kirksville, Missouri back in 1892. And he's actually made 4 books talking about this philosophy and the treatments, which has evolved over the years. But first, it highlights treatment of physical and mental ailments, which we are going to deem them as diseases, while emphasizing normalization of what's not moving well in the body. So body structures, the functions, as we believe that structure and function can influence each other. So for the osteopath, we focus on that. And then the hallmark was detailed the detailed knowledge of anatomy that became the basis for much of the diagnostic and clinical work that we utilized. Most notably, we palpate the human body, see what's off, and then we make a diagnosis based on that, and we create a treatment plan based on that for the patient. That's our script for you. So the second emphasizes how important health and well-being in the broadest sense, including your mental, your emotional, spiritual health, and avoidance of certain vices like alcohol, drugs, and other negative health habits. So all in all, we bring the body structure, the mechanics, in order to treat disease processes, as I would try to find root cause. So influences, he was influenced by a lot of philosophers, scientists, medical practitioners of this time, very well versed in religious philosophies, concepts of the Methodist and spiritualist and universalist movement at that period. And then following, he had lost his 3 children to spinal meningitis back in 1864. And he immersed himself in study of nature of health, illness, and disease. And as a result, he discovered this system of medicine. So he believed that there was a God of truth and that all his works, spiritual and material, are harmonious. His laws in animal life is absolute. So why is a God that had a certain place to remedy within the material house in which the spirit of life dwells, meaning the body? He believed he could access these natural inherent remedies. And by adjusting the body in such a manner that the remedies may naturally associate themselves together, hear the cries, and relieve the inflicted. And so, as in that, basically, that revelation that the physician does not cure diseases in his view, it was the job of the physician to correct structural disturbances so that body works normally, just as a mechanic adjusts the machine, allow the body to way to heal itself. So we call that whole philosophy osteopathy. So we actually, I'm not going to read the whole thing, it's pretty long, but this is how many of the osteopathic doctors who practice osteopathic medicine, they keep this philosophy in mind in how we approach our patients and treatment of our patients. So it leads to 4 key principles in our profession, and that the body is a unit made up of body, mind, and spirit. The body is capable of self-regulation, self-healing, and health maintenance. Structure and function are reciprocally interrelated, and rational treatment is going to be based upon the understanding of the basic principles of body unity, self-regulation, and interrelationship of structure and function. So that's where all of these ideas come in as to create what the osteopathic approach to treating patients in our philosophy towards doing so. So as a result of how these tenets are arranged, we as osteopathic physicians claim to be holistic, claim to be patient-centered, as well as opposed to disease-centered, like the medical doctor. And we also assess the diagnosis and treatment of dysfunction in the neuromuscular skeletal system. So what that means is that this is a little bit of a model. Out here is your environment. This is a human body. Right here, this gray circle. So what that means is that this is our body, and within it, things that affect our body health, overall health, and how we deal with stressors. Our posture, posture and motion. How will our body circulate the body fluids? Our musculoskeletal system. How we behaviorally adapt to stressful situations and disease. Neurological balance, how neurologically how we react and balance, and our metabolic and immune systems and how our glands help us to regulate all of this as well. So our body works with all of these in order to deal with the environmental stressors such as trauma, infection, how well our nutrition is it good nutrition? Is it bad nutrition? And our social factors. Are you in a happy environment? Are you in an unsafe environment? Are you in a stressful environment? Such things as that. So as a result, we created 5 treatment models, namely our biomechanical, which is that postural and our body mechanics. Then our respiratory and circulatory model, which is how our breathing and circulation also contribute to keeping us functioning and living. And then our neurological function, how our neural integration in controlling the world, our autonomic balance and center peripheral nervous systems allow us to adapt to our environment and to diseases and stressors that can influence us. And then metabolic energy. That is the endocrine system and our immune system, as our endocrine system does regulate how our immunity functions. And then behavioral, our spiritual functions, our emotional, our healthy lifestyle, and our social support system, how all of these play a picture into how we promote and take care of ourselves and others. So as TLs, we may evaluate our physical, we'll evaluate your physical, mental, and spiritual components. This is what to expect if you ever come to see us or have come to see us. We assess, are you safe at home? Your personal safety. Sufficient, are you getting enough rest and relaxation? As that sleep is so important in our healing, and which you'll see, especially with patients that have symptoms such as fibromyalgia or something called central sensitization. How well you're sleeping, are you getting that recovery phase of sleep? And as that can affect so many different things. Are you getting enough proper nutrition? Are you eating healthy? So that may play a picture in certain conditions like diabetes, which may influence how well you heal. Regular exercise, stretching, strengthening, that helps with that posture component. As so many things, and a lot of research is going into how our body fascia moves and how it is incorporated to how our body systems are able to recover from disease. And maintaining social relationships, rewarding ones, not bad but good. So being happy, you usually feel healthier when you're happier, right? Versus when you're not happy, you feel like, oh, the world's crumbling around you. So maintaining that happy balance with your life around you. And then avoidance of those vices, those bad vices, like tobacco and other drugs. Won't go into marijuana, but and then eliminating or modifying any kind of unsafe environment. So also work-related behavioral patterns, like if you're tired, getting home from work late, things like that, never really having time to adjust your family, the work-life balance thing, sometimes that can affect your health as well. And then avoidance of environments for radiations and toxins. How are you doing with that? So we want to know all of these things about you because all of this plays a factor in your overall health. So what happens at the osteopathic, what happens before we actually do the treatments, that your DO will ask about your symptoms, all those questions, and any other health concerns. And then it's important to share information about your sleep habits, activity level, your diet, your mental health. DOs also use this information to gain a clear picture of how your lifestyle affects your overall well-being. And then they'll examine you by touching and pressing areas that you may find that that you've complained about there's pain in that area, or if it's really painful, maybe an area that can refer to that area so that you're not in an uncomfortable position when we're treating you. So then depending on your symptoms, your DO may order imaging before the start of the OT. May not find it appropriate for you to be treated with the osteopathic treatment without further workup to see if it gain more insight of what's going on. So the treatments are hands-on, they're hands-on method. And then we use those treatments to, almost like the mechanic, we assess your muscles, your tendons, bone pain due to maybe structural imbalance, maybe one leg's longer than the other, things like that. Maybe your gait's off because of that, and it may be contributing to hip pain or back pain. So we assess all of those things about your biomechanics, and then we also use osteopathic, and then eventually we'll use the osteopathic treatments sometimes to diagnose as well. And there's always the in the back of our minds that if there's a chance to prevent disease and help your body function better just because you're moving better, that's always as part of our workup and part of our treatment plan for you. So the goal overall is to encourage your body to heal itself, ensuring that your bones, your muscles are aligned and balanced properly. But we're still taking into account all of those other factors that can influence how you're doing. So who gets treated? Breathing issues like asthma, sinusitis, congestion, bowel issues such as irritable bowel syndrome, constipation, chronic pain. I mentioned fibromyalgia before, arthritis, sometimes menstrual pain, migraines, musculoskeletal problems like back and neck pain, joint pain, carpal tunnel syndrome, a whole bunch of stuff. So I'm going to hand it over to Dr. Burke.
Thank you, Dr. Hall. Thank you very much. All right. Yeah, that was great. It's interesting that so many people haven't heard of osteopathic medicine, but it's a uniquely American approach to medical and surgical treatment. It was founded as a philosophy, primarily, not just a manipulative treatment. And the first school opened up in 1892, and I do want to set the record straight that I was not in that class. But the World Health Organization has recognized that respiratory circulatory model, one of the models that Dr. Hall talked about, as being a significant contribution to modern medicine, even though it's kind of an older model, because it's a unique model that looks at how the body's diaphragm and rib cage generates pressure differentials to move the low pressure venous and lymphatic blood, or I should say venous blood and lymphatic system, which drains debris out of the interstitial space where the cells live. And it's really important to drain that lymphatic system, because if it starts to break down, you start to swell up and you start to feel sick and toxic. So it's a really unique approach to looking at that model with your hands at these transverse diaphragms that occur at spinal junctional areas. And why that's important is the patient could have pain in their knee, and the primary area you have to work is up here to drain that, because the right knee has to go all the way up that lymphatic system and drain up here. So that's an important thing. And then I always like to add in a little bit of trivia. So you guys know who Sir Conan Doyle is, right?
Okay.
He wrote Sherlock Holmes.
Oh.
And the Watson character was based on William Smith, who was an MD surgeon from Edinburgh, Scotland, who came to Kirksville, Missouri to study with Dr. Still, taught at the American School of Osteopathy, and subsequently became a DO and went back to the UK and practiced for the rest of his career in the UK as an osteopath. So you never know if you'll need that on a game show. If not, you heard it here. Okay, so I apologize in advance. This is based on a lecture of third year, bless you, osteopathic medical students. This concept of central sensitization, which is a change in the characteristics or behavior of the nervous system, and why that's important in certain disease processes. So what it is, it's a state in which repeated stimuli to nerves, certain nerves in particular, leads to a progressive amplification of the response. So what happens is these nerves, after a while, start to say, a little bit of impulse is coming in. No longer am I just going to do something that's in step with that amount of input as far as the output. Now it's a much more heightened response. And it's dependent on these unique small nerves, these nociceptors. And it can involve both nerves in the periphery as well in the spinal cord and central nervous system. And the new term for that type of pain is called nociplastic pain. So I won't be quizzed on that, but if you ever come across an article, you may see that. Why is this important? These are the conditions that are known at this point to be associated with central sensitization, and more research coming on about this stuff. So it's quite broad, and it's quite relevant to someone who deals with manipulative treatment of patients coming in for pain. So again, I apologize for the slide, but these little nerves branch all the way through your body. They're everywhere, basically, in the connective tissues, around the muscles, around the blood vessels. And they typically respond to three things. If you have mechanical strain where there's force coming into the tissues, compressing the tissues, or tractioning the tissues, they'll start to fire. If you have a thermal injury, a burn, or too much cold, but also chemical. And the chemical comes from chemicals that are released by cells or the nerves themselves. They start to trigger and fire these nerves that then go back into the spinal cord. And that process, when they release neurotransmitters to fire off the nerves, is called neurogenic inflammation. So it's a type of inflammation, and this serves a protective role to splint you. So let's say you broke a leg, it hurts, you're going to lie there, you're not going to move. Well, theoretically, that's going to help start the healing process. You don't want to be up and walking around with a broken leg. If you rupture an appendix, your muscles around the abdominal wall are going to splint down and you're not going to move. Theoretically, you may get some healing response for that. 2,000 years ago, they didn't have surgery, but that was something kind of hardwired into the system as a protective mechanism. What happens, though, is that when the injury resolves, you still get that behavior in the nerves. So it's a dysfunction in the nerves where they continue to fire. This is the slide you'll be tested on at the end of the evening. So you get increased responsiveness of the nerves and then increased pain sensitivity in a wider area as well. You can forget about the right side. It's for the medical student. And this one too, you can forget about, other than if you look at the picture, nerves are coming in here. This is to depict the spinal cord, and then nerves come out over here. Here you see the little branch that goes up there. So with repetitive stimulation of these nerves that are hyperactive and always triggering, you get certain nerves that deal with crude touch or light touch that go into the area of the spinal cord that interpret pain. So now with chronic pain patients, what you see is very gentle touch in some patients can be painful, very painful. And it's not because it's all in their head, it's because there's plastic changes in the central nervous system. We have sprouting into other areas, so it's interpreted as being painful because it's being processed in that portion of the spinal cord. So this is part of the plastic changes that occur in the nervous system based on this ability of these small nerves to get sensitized and hyper-irritable. It eventually deals with changes in the spinal cord itself, just like we showed, and also the central nervous system. It doesn't process the sensory input no longer the way it should. And what the central nervous system is supposed to do is also through the descending pathway, the nerve fibers that are going down to quiet things down and modulate things. That goes awry as well. So certain things tend to precipitate people getting central sensitization. Sometimes it's genetic, sometimes it's modeled behavior that they learned as a child. Emotions and mood can play a significant role. Trauma plays a big role. A lot of post-traumatic stress patients, you'll see central sensitization. So it's important because you get this vicious cycle where you get those nerves out in the periphery really irritable. They're causing changes in the spine, and that works its way all the way up into the central nervous system, and you get this central sensitization. And so see, these are some of the symptoms that are associated with central sensitization. Hypersensitivity, obviously, to noise, touch, bright light, to pesticides, and then this says might be related to it. This is from an older article. This should all shift to the left. Sleep disturbances, unrefreshing sleep, concentration difficulties, swelling in the limbs, tingling in numbness. With fibromyalgia, we see this often. You see the sleep disturbances, non-restorative sleep, and there's actually, a mechanism in which the sleep cycle is disturbed. The hypothalamic pituitary adrenal axis is your main endocrine or hormonal system that helps modulate stress, and you see that this gets dysfunctional as well. this means the sympathetic nervous system. It's the fight or flight response, and that can be dysfunctional, either too high, really stressed out, or even it can start to come down. So, and then you also see decreased blood flow in certain areas of the central nervous system that would be involved with modulating some of these responses. So how do you approach a patient with central sensitization? Well, we use fibromyalgia as kind of the typical clinical scenario. There's a whole host of medications that are very helpful, but it's a multidisciplinary approach. Cognitive behavioral therapy is very important. Physical therapy, occupational therapy, low impact aerobic exercise is very effective. And strength training is also important. There's a problem with the aerobic exercise though. With patients who have central sensitization, they get really sore when they do. It activates in non-sensitized patients the endogenous, the opioid system you have within your body. But in patients with central sensitization, it increases their pain. So they really have to take it slow and steady. And even afterwards, they can get trigger a release of these inflammatory mediators, leading to a real sore feeling after they push themselves. So what does that mean for people who do manage patients with manipulative treatment? So that means for us, when we put our hands on patients, if you know, in some patients you put a hand on their shoulder and it's painful, how are you going to put your hands on and manipulate tissues? So many times you really have to be paying attention to how you're addressing the patient and making sure that you're only giving them the amount of dosage of treatment that they'll tolerate so they don't get some of these post-treatment reactions. And any therapeutic intervention can trigger a painful flare. And so when we're using our hands and treating a patient, we're looking at things like the body language for the patient. Respiratory pattern is a big one because when you start the treatment, they're breathing fine, and then all of a sudden their breathing changes. Then you got to ask yourself, check in with the patient. And also the tissues may tighten up because they're getting more spasm. We're always basing our treatment based on the feedback that's coming from the patient. Other considerations are important: mindfulness meditation, Tai Chi, and there's some nutritional stuff as well. So I'll preface this slide by saying I'm not telling you to take any of this stuff. You have to do that in conjunction with your healthcare provider. But there are some supplements that can play a role in helping these patients. Hypermobility in patients is a big factor that's associated with central sensitization. So patients whose joints are not so stable through the ligaments that are surrounding the joint capsules will have more pain and more central sensitization. These are just some tests we may do in the office. You may want to try these or not. But why this is important is because we call direct techniques are kind of contraindicated with a patient with hypermobility. So what the direct techniques is, let's say I can't turn to the right, and then we just take my neck and go to work our way right through that. So the normal range of motion in the neck is about 85 to 90 degrees both ways. I'm pushing it, but I think I'm pretty normal there. Let's say I can't turn to the right. That's within the physiological range of what's expected. And so if you do, just push it through, not bad. In a patient with hypermobility, they'll go even further than the 90 degrees. So if they have a restriction here and you're going to try to push it through, you may actually push it through that anatomical barrier and sprain the ligaments even more or worse. So that's why you definitely want to know if your patient has this, what type of approach you would use from a manipulative perspective. So in general, with osteopathic hands-on work, the approach is going to be varied and unique to each patient. You want to address the areas of the spine, what we call in osteopathic medical school, acute changes first. They feel like they're acutely injured. So the muscles around the spinal segment will feel warm and boggy because they have some inflammation there. And then when you try to find how the joint moves, it's not like, oh, it just stops. If it just stops abruptly like that, that means more than likely you can do one of those thrusting techniques or popping techniques. But when you have a central sensitization or facilitation in that area, you're not going to get that feel. You're going to get like, oh, this it's restricted, but it's really springy. If you tried to do one of those popping techniques on it, you would fail. It would not work. And actually, you can make things worse for the patient temporarily. And that's what the next point is. When you address patients with this, painful or rapid maneuvers are going to increase the spinal sensitization or facilitation. So we would approach this at those acute segments with what we call indirect techniques. Indirect techniques means they'll say, I can't turn to the right. Well, I'm going to go the way it likes to go, to the left. So why would that be a treatment? If you think about the bureau drawer that comes out and you can't push it back in, you exaggerate a little bit more and it'll go in. Same thing with connective tissue. It has resiliency and will go back that way as well. So let me talk about rib raising as an approach where you're dealing with the fight or flight nerves. They're in relation to the heads of the rib in the back here, close to where they come in contact with the vertebrae. And then we have some connective tissue, which is there's a continuity with all the connective tissues from the feet to the head and from the outside of the skin here all the way down to the deep tissues of the body. And so this is that respiratory circulatory approach where there are these transverse diaphragms that function as potential dams to low pressure circulatory mechanisms that are coming up and ultimately have to dump into this area up here. So when there's muscle tension, let's say in the respiratory diaphragm here between the lower ribs, it's not going to move too well. So let's say these are this is the diaphragm under the ribs, and one side here doesn't move. You breathe in, out, and this side just moves a little bit. You're not going to get good drainage up through here. And so how do you approach that? Well, you have to be able to evaluate it. And one of the early osteopaths talked about nobody is perfectly symmetrical. Part of that has to do with hand dominance, lower extremity dominance, but also the fact that you have the liver on one side puts a little bit more weight there. But he found that the connective tissue preference for rotation will alternate throughout the body if the patient is asymptomatic and pain-free. And the common one is this one here on the left. Well, 20% is this one in patients that don't have pain. When patients have pain, those connective tissues don't rotate in opposite directions. So then you can do gentle soft tissue work, fascial work, and simple technique like this, just to get the muscles to relax and allow that diaphragm to work a little bit better. We also want to address the central nervous system. So just the relationship of how the head is sitting on the first cervical vertebrae, as well as the blood flow in and out, and especially to impact the hypothalamus, which is controlling the autonomic nervous system. The ANS is the autonomic nervous system that includes the fight or flight and the parasympathetic nervous system, the vagus nerve and the other parasympathetic. So every patient is unique, and the goal is to help them optimize their function. So by the end of tonight, everyone.
Yeah. Sure.
Okay.
Sure.
Yeah, but this area of research, sexual sensitization, is really exciting. It's a new area of research that's come more and more is coming out about it. But you got to remember, medical advice is always changing.
But I am going to show you a couple of the techniques that we do. This is something called HPLA. This is like more of those more direct techniques. So usually this is used to restore motion to previously mobile articulation, but it's really restricted. It's fibrotic, it's down. But you know, if you have central sensitization, we most likely will not do this type of technique. We also have something called muscle energy that only certain populations get that type of treatment. So, because everybody's not going to be treated in the same way. Everyone has different ailments, and certain techniques are good for some people, while other techniques are not good for other people. So, contraindications to treatments like that would be if they don't have any problems, for one thing, which is why I'm not treating these. If the patient doesn't consent, they're not, or they can't cooperate, is there a fracture, is a dislocation? Because at that point in time, like Dr. Burke said, you're trying to protect that segment from the fracture. Your body's telling you not to move for a reason, so it allow it to heal. So as a result, you don't do treatments on those. These type of treatments on areas where there's fracture. If there's have bone metastasis, like in the case of cancer, to the area, you usually don't treat that area either with these direct techniques, as there is consideration that maybe there may be some seeding or spreading from the tumor, and also that bone is a lot weaker. So as a result, we don't do those treatments if you have cancer spread to the bones or anything like that. Osteoarthritic changes that are really fused together. Don't recommend those type of direct treatments because they're fused. So as a result, we can't really necessarily offer too much motion. And then there's also that central sensitization factor as well that plays part of why you may have increased pain if you try to go through a joint. Then Down syndrome. Usually those patients are usually hypermobile, and as explained by Dr. Burke, hypermobility may miss the barrier, and then you have increased pain. And as a result, you may end up causing more damage to the patient than others. So certain techniques, certain people, they're not a cookie cut list for every single person. So as the osteopath, we modify. So cap restraint, actually, this is a more gentler treatment that we may do. This is a treatment of like a psoas tender point, which is a psoas muscle is your hip flexor. It allows you to be able to sit. Sometimes if you're lifting something and you kind of strain your back, very common that muscle is one that's pulled. So you may notice after you sit and you start walking, you kind of have like a forward kind of lean motion. And then after a while, after you walk for a little bit, you're able to stand a little bit better, a little bit straighter. But you got to get going for a little bit to loosen up that muscle. Oftentimes the psoas muscle is that problem. It's not always the problem, but occasionally it is. So contraindications to that one are going to be also fracture dislocation. As you can see, I have her in a different position. If you have a hip fracture, you don't want to be in that position. You're trying to protect the stability of the fracture. So we're not going to do that kind of treatment on that area. Probably will send you to ortho to stabilize your fracture. And then, maybe post-treatment wise, we may utilize those after you're fused and you're better and you're stable. And if you still have some fibrosis around that area, we may come to these type of treatments that are much less stressful on the body. We call them indirect treatment. Once again, metastatic bone to metastasis to the bone or soft tissue, just because we're concerned about seeding potential, we would recommend not against these type of techniques to the area. And then also any kind of acute reactive like rheumatological inflammatory conditions to that site, we would warn against as well. And then we usually would treat different areas rather than that area site. Like if you, like for instance, like that psoas muscle, probably wouldn't treat that area directly. And then we'll do lymphatic treatments. So treatments like this are going to be like your lymphatic techniques. So these are going to be very gentle, and they're not directed at treating any specific area, but more so treating the circulation. So usually at these treatments, we may direct treatment at the abdominal diaphragm, which is located under the rib cage. Sometimes the pelvic diaphragm, which is located at the seat of the pelvic floor. And sometimes we always make sure we assess an area called your thoracic outlet. So that's the most common, where most of your fluid is going to empty, is on your left side, the thoracic outlet, in this area right here, your thoracic duct. So we always do certain treatments, very gentle. My hands are just touching. And then I just kind of assess and take her tissue where it wants to go. So I'm taking tissue where it wants to go, much like how Dr. Burke just described it. We're taking tissue where it wants to go, so it allows it to say, tissue, it's okay to release. And then once that releases, we reassess. And usually there's a lot more movement Other things that we may do, much like this, pectoral traction. That's just grabbing at the area of the pecs where they connect at the shoulders, and then just give it a slight tug. And that's basically, we're taking the tissues so that they can release. And then once the tissues just kind of release, that usually is enough to release that area. So now more movement of fluid can exit the body and flow throughout the body. So that's usually good for if you have lymphatic congestion, like such as some people have lymphedema. Congestive heart failure may also encourage some swelling, or if you have a low protein intake, and that's that nutritional model. Once again, if you have low protein, you may have not a good colloidal pressure, and then as a result, you may start to turn third space, and then your fluids go outside of your blood vessels and into your interstitial fluid. I'm sorry, into your interstitial tissues. So as a result, you may swell, puffy, things like that. Some of these treatments actually help with that, just because now you're improving your respiration and your lymphatic flow. So things that we probably wouldn't do this, well, we always take into account if you have severe heart failure. Usually what happens with severe heart failure, your heart, the pump has failed and it's not pumping very well to be able to circulate. So then there's always a concern. It's like if you bring all the fluid that you're third spacing in the soft tissues back to the circulation, is your heart that's weakened to that point? Is it going to be able to handle all that blood flow now that all that fluid is back? So sometimes it may cause an exacerbation of severe heart failure. So for these people, we still incorporate all the other modern treatments such as diuretic use, which is the water pills, and modifying, making sure that you're urinating. We may utilize some of the OMT techniques to help with what in conjunction of those things to help take the fluid from third spacing and help the body come back into homeostasis. So a lot of these treatments are to help the body heal itself, but sometimes we need a little bit of a little addition from outside, you know? And then the cranial stuff. So the cranial is part of the osteopathic medicine world, in that we are treating patients with where our movements are directed at freeing up the cranial bones, the sutures between the bones, as our cranium is made up of multiple bones, and then they, much like here, there's a line right here, and they fuse and they move and they pump. So they're actually pumping in order to help circulate the fluid in your brain in order to keep it nice and moist, and also to clear metabolic waste, and also bathe your central nervous system so it doesn't dry out, of course. But it produces, that also goes along with the respiratory model. As we're breathing, that helps the pumping of that. So when we do cranial, sometimes people may have some restrictions in that. Maybe they had meningitis as a child, or maybe they had concussions, maybe they have a history of migraines, multiple different things. So the cranial approach actually helps with that, bringing up that restriction in the bones. And then also there's areas in the brain, all sciences, where that fluid actually bathes. Cranial helps pump that so that it's more efficient fluid flow. So treatments, usually osteopathic sitting. I'm gonna stand because there's no chair, but sometimes we may do gentle techniques in which we just kind of separate the sutures, much like our sutures right down the middle. So just kind of just open and stretch a little bit until we feel a release. And we're just basically doing it so we feel a release of tissue. And she has multiple different sutures along the brain. So we're also looking to see, is there restriction along those sutures? So bringing up those restrictions and then assessing to see how her cranial rhythm is moving. So that may actually help with her increasing her flow in her brain and maybe enhance her pain relief. Sometimes you see these restrictions also in patients that are very depressed. Sometimes they may have a decreased cranial rhythm as a result. So sometimes this may actually help with that as well. All right, so contraindication if you have skull fracture or seizures, or if you have a space occupying lesion like a tumor, I wouldn't recommend it. Or if you have increased intracranial pressure, like something called hydrocephalus, or so we don't recommend against these things. Or if you have lack of consent, of course, or no dysfunction. So what to do after you're treated? We usually recommend drinking plenty of water, hydration, and that allows toxins to flush from your muscles. Oftentimes, your muscles haven't been moving in the way that they are supposed to be moving. So now, when you get into treatment, you may be moving better, but your muscles don't know that. So they're kind of trying to remember what they used to do. So you may have an increase in lactic acid buildup and other metabolic waste of the muscles. So drinking water and staying hydrated actually helps to flush those toxins out and also to stay hydrated and help with muscle spasm. So it helps with your recovery in general. Also, sometimes just staying active as we've been enhancing throughout the whole talk. Walking, you don't have to do like intense walking, speed walking, or we don't expect you to run a marathon or anything like that. Gentle things that are more relaxing, but just to stay active. And just taking it easy, avoiding any of those rigorous physical activities for at least 24 hours after OMT. But if you have a symptom sensitization, I would recommend not doing those intense activities. You just want to be gentle and doing activity to stay active. So sometimes yoga, gentle yoga, chair yoga, it's like that, it'll be helpful. Overall, OMT techniques are safe. They're usually not side effects involved in the procedures. Maybe some post-treatment pain, which should go away at an average of 72 hours. But severe pain, if you do have severe pain after an osteopathic treatment, that's not a normal side effect. So you should actually give us a call back and just let us know about that. So we just reassess. And patient population, all genders, gender identities, all ages, athletes, pregnant patients, literally anyone who needs our services. But the osteopathic doctor will evaluate each person individually to make a treatment plan individually for you based on what you have. So, and taking into account those contraindications that I spoke about earlier, if it's safe, it's performed. If it's still a procedure, it's not, we do not trust that it can be safely performed on you, then we will not perform that on you. Right. And then I also had this question about what's the difference between the osteopath and the chiropractors. I decided to incorporate this slide. So osteopathic doctors they hold a medical degree and they have the same medical rights as the MD. DOs also have the right to prescribe medication. They're highly trained practitioners who are more interested in the person's entire body and that more holistic approach. And then they will also provide a wider scope of treatments, including treatments involving other organ systems. So even though we do manipulation, not all, you'll find that sometimes when you're looking for doctors or doctors that you come across, some of them might be a DO, but they never perform osteopathic treatments because it usually is a specialty. The osteopath has decided to go into. Some doctors, they may be DOs because they graduated from the osteopathic school and they may become a neurologist or ears, nose, and throat doctor, but not everybody does the manipulation, but they were trained in it at some point in their career, but they just opted to go a different pathway in their careers. So versus chiropractor, they hold a doctor in chiropractic medicine, and then they cannot write prescriptions. The osteopathic can't prescribe medications, and also do certain procedures that are more invasive, like surgeries. I can't perform surgery on primary care. I'm not going to, you don't want me cut into. But if they've gone through surgical residency training, they can do that. And then when indicated, usually the chiropractic, doctor of chiropractic medicine will they often do consults with us. Sometimes they do refer to us as well. And they may co-manage along with the patient, but they don't provide the injections, medications, things like that, what osteopaths do. And they usually do manipulation to the spine. They focus more essentially versus the osteopath. They tend to be more broad and take the whole body into consideration. But everybody performs a job in taking care of the patient. Even though the chiropractors and osteopaths and medical doctors, we all work together in the professional field in order to care for our patients in general. So some of the treatments that we may also incorporate trigger point injections into articular injections if you have joint, like say severe osteoarthritis in the joint, and maybe you don't want to do surgery or you're not surgical candidate for some reason. So some of the kind of techniques that we may do is into articular injections. And then sometimes we may utilize ultrasounds to help diagnose and maybe to aid the treatment. Regenerative medicine, some doctors, some of the osteopaths do that, some of the MDs do that actually. Regenerative medicine is the prolotherapy, prolotherapy, PRP, those also known as platelet-rich plasma. Those are directed at trying to create a space for the joint to recover itself. So those are more injectable things that they do inside. If you're not surgical candidate, it's not for everybody. So, and those procedures are very hit and miss and often not covered by insurance. But osteopathic treatments and trigger point injections, those are the ones are covered by insurance. So usually we won't do those other ones unless you're pretty much exhausted like everything else. And then hydrodissection, which is using high pressure saline to help cleave out a nerve that might be scarred down. Sometimes we may do that or nerve blocks. Summary. The osteopath will address primary causes using available evidence-based practices. The whole point is to enhance the patient's healing capacity and individualize patient management plans with an emphasis of health restoration and disease prevention. We use our palpatory skills and manipulation to help on the somatic dysfunctions, the structure, the posture, things that could be affecting your health and your pain and your posture and your mobility. And then using the osteopathic philosophy is meant to guide osteopathic physicians in the best use of scientific knowledge to optimize and diminish any kind of disease process.